Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about a 67-year-old male who came to our ER with complaints of hand pain and swelling for the past 10 days. Initially, on initial assessment, patient was conscious oriented, and primary assessment was everything was within normal limits.
Okay. So can we directly go into the local examination?
The local examination history is like he's a 67-year-old male, known case of type 2 diabetes, on metformin 500 mg OD and glibenclamide 5 mg OD. Came to the ER with complaints of history of an injury of the right hand over 10 days back. And 3 days he was having a history of like trauma, and following the trauma 3 days after the same, he developed pain, swelling and itching, and the whole symptoms were gradually progressing over the period of time. And for the same, he went to the nearby hospital, and there he was started on antibiotics. Tab amoxicillin was given for 3 days. Still, patient was complaining of the same symptoms, and for the same, he came to our ER for further management.
Okay.
And on the evaluation, initially his hand was having swelling, and there was local rise of temperature. Tenderness was there, and there was slight darkish discoloration, like a necrotic patch as such was seen.
Okay.
So for further evaluation, we went ahead with the lab investigations, and the lab investigation.
No, I just want more about local examination.
Local examination.
You just said regarding
There was
swelling result, but I wanted to know when you do a local examination, you describe regarding the swelling. Then you need to think about the adjacent structures also. Can you just elaborate
adjacent
on that?
structures, he was having difficulty in flexing the wall fingers.
Okay.
And there was as such the whole limb was reddish darkish color.
So first let's start with appearance. Appearance, it was swollen and it was red in color, and there was a dark necrotic patch. So that is the one thing. So next thing is that what are the adjacent structures that is getting involved? Whether it has affected as functionality. How is the neurovascular bundle near to that? So these are the question. And any hand space or any other infection, whether it has led on to any other complications. So this you have to tell me.
So
Functionality, as you said, it is having pain or if is unable to do. That is a question. If it is a pain, then it's a different scenario. Whether he is unable to do the movement, then it's a different scenario. So whether it is painful flexion or extension of the fingers, or because of the edema is unable to do that, or he is not having power because of the nerve injury, or whether it can be due to the direct tendon injury also, this is a possibility. So what is the
due to pain, due to flexion, he was unable to flex the whole fingers.
Okay.
And then all the pulse was present over the radial and ulnar artery. Then
okay, we are thinking of as a hand infection. I would be more like to see what is the capillary refilling time in this area. I would like to put a saturation probe on that limb, just see how is the circulation. All those things, that's what I will look into. And mostly we need to look for stretch pain, maybe an early feature of a compartment syndrome. We need to look into that. And next is nerve involvement. Which are the nerve involved? What was the type of trauma, whether it was a direct cut injury or it was a crush injury. So all those things is very, very important. What is the level of injury? If I am having a level of injury higher up, and whether there is a swelling down, and whether the patient is unable to move the limb. So I need to think of a higher injury. So all those things you need to look into. And when you do a hand examination, what all things you need to do? The most important thing in a hand examination, not in this condition, generally when you look into a hand examination, you need to keep it compare with the other limb, other hand. So that is the first thing. Then you need to start describing the swelling, if anything. Then deformities, your obvious deformity. Then all the movements, adduction, abduction movements. Then what are the tests that you need to look in for the hand? And when you are suspecting a nerve injury.
Nerve injury, okay sign, then pop sign.
Simple test, pen test you can do. Paper test, you can ask them to grasp a paper in between, and then book test. So these are the simple things that you can look in for. But in this situation, there is a infective pathology, so most likely we'll be unable to do these things due to pain. But whenever you are getting an hand injuries, like especially an open hand injury, tendon injuries, especially when you are having at the level of elbow, you need to definitely evaluate whether there is an ulnar nerve involvement, median nerve involvement, radial nerve involvement, whether what is the sensory differences, only the sensory part is involved, or whether it's a deep motor branches are involved. All those things you need to see, and we need to have a proper evaluation. Because of pain, I am saying that you need not do these things, but here you need to look into the complication, the most important complication being compartment syndrome. Why you can have a compartment syndrome in this area?
So most common areas of compartment syndrome are the upper and lower limbs, and mostly in hand we have multiple spaces divided by the fascias.
Okay.
So space of Parona and all are highly.
So why a normal simple paronychia is not going into a deep palmar abscess?
Because of the
so how the usual anatomy location? You have got deep palmar structure. So we have got segment divisions. So we have thenar, hypothenar and deep palmar space. So usually what is the problem when an infection is happening? It can down track into the corresponding tendon, and it can go in further, and it can go into a deeper muscle space. And mostly when you look into the compare our this area and this area, these joints are very superficial. So the joint can easily get affected. The synovium can easily get affected. The small joint synovium can very quickly get affected. But when you look into this area, there are a lot of other muscular structures. So the synovium, everything is little bit deeper. So that wise here it is very prone to develop because of the anatomical differences. And usually when you think in terms of an abscess, you need to say exactly where the location of abscess, whether it's in the thenar, hypothenar, or whether it's in the center in the volar aspect. So you need to tell that. So where was the location of this?
This was mostly or the deep palmar space in the metacarpal. Correct space will be in the region of second and third metacarpal headman.
Okay, fine. So now this is the patient that has come to the ER. So we have made an assessment. Probably the classical history what you will get in any hand infection is that it will be starting off with a trivial trauma. So that is a classical history. You won't get a deeper like a deep cut wounds and all. You might get, but classically what all things can cause like this. One most common one is
thorn pricks, then animal bite.
Small thorn pricks, animal bite, very common. Last 2-3 months back, we had a patient who had been just bitten by a cat. No comorbidities, only age was a risk factor. He developed a deep palmar abscess. So this is because of the location of this thing, you can rapidly the infection can spread. So very, very important. You cannot take it lightly. You need to treat it with significant IV parenteral antibiotics depending upon the comorbidities. Here there is another risk factor. He being a diabetic on top of that uncontrolled diabetes mellitus. And other immunocompromised like malignancy and all, immunosuppressant and all, they are at higher risk. Maybe a simple paranoia can lead on to a deep palmar abscess for those group of patients. So one thing what we need to differentiate, there is something called as palmar tenosynovitis, infective palmar tenosynovitis. So when a patient comes to you, there is a mild swelling. 2 weeks back we had a similar patient who had come to the ED. She's a diabetes under control. There is no as such history of any trivial trauma. There is nothing. Suddenly, within 2 days, she started experiencing pain and mostly over the thenar eminence, and she is unable to flex the thumb. So that was her complaint, and there was minimal swelling. So in that situation, suddenly a 63-year-old female, and why she should develop this? So that is something called as infective palmar tenosynovitis. It can be inflammatory also, but since being a diabetic, when we examine her nails, there was a lot of fungal infection. So whenever you are seeing, because they will be using a lot of utensils in the kitchen and all those things, they are very prone to develop this infection. So even if there is no trauma, the bacteria can easily penetrate and they can go and cause this infection. So that you need to differentiate. So this is clearly you are able to see as an abscess, redness, there is a necrotic patch, something like an anaerobic infection has already been set in. So that is one thing. But this is another group of patient where when you look into the lab investigation and all, the CRP and all will not be that elevated, but they will have significant symptoms. So it can be inflammatory, but it can be infective also. So infective versus inflammatory versus a deep palmar space infection, you need to differentiate. So the treatment aspect, you need to have differences in each category of patient. But the first, this patient, how we have managed, you need to tell me now. So now, our agenda, we have seen that there is an abscess that has been there. So now, what is our next question?
So for the same, we had initially we'll go ahead with the investigations, and in investigation here we got raised inflammatory markers and
blood investigation. You leave it because it will be invaded for any infections. So we will be doing the routine panel of investigation, whatever you do, and you will have inflammatory markers elevation. Radiological investigation, whether you wanted anything, if so, what is your investigation of choice?
Radiological investigation as such, we can go for an X-ray. X-ray can show if at all there is any joint space involvement, bone involvement, or gas as it is there. Or else we can go with a higher imaging MRI or CT, which will show the extent of infection.
Okay, maybe something in between you can put an ultrasound also. Ultrasound is a very good tool when you have suspicion, like whether it is just a palmar tenosynovitis, whether it's just a palmar space tenosynovitis which is infected, or whether there is a local abscess. But when you have a full-fledged abscess that you are able to see in your naked eye, then you need not have an ultrasound need to be done. As I said, maybe you can take an MRI. It all depends upon how the treatment is being planned. You need to know the extent of infection. This has been already been 10 days and already he was on antibiotic for 3 days. So that was the reason maybe we had gone for an MRI, but routinely to confirm your diagnosis, you did not have any of this investigation. You can straight away go and do an IND and drain out whatever be the pus is there, and then you can send it for culture and sensitivity. So that is the surgical management as such. Now the antibiotic. Suppose you have got a patient in these 3 categories. So as I said, maybe a simple palmar tenosynovitis infected, and you have another group of patients, you are having a deep palmar abscess, what you are having in this group. So what you select as an antibiotic?
So mostly the patients will be having a Clostridium infection or Peptostreptococcus or Bacteroids. Along these are the most common and
most
also
common?
Then
most common, what is most common in the skin?
Anaerobics and E. coli.
What is most common in the skin? It is gram-positive.
Gram-positive.
It is strep and staph. You can't tell them they are the first organism. So they are the problem makers. So strep and staph, after that you can tell all those organisms. Then you need to look for the risk factor. So there are certain group of patients. You need to ask them what was the type of injury. So this patient he was doing some removal of coconut husk. During that time he developed this. So it has been whether it is a tetanus prone wound. That is the next thought process. Tetanus prone wound or not requiring any tetanus prophylaxis. That also should be kept in your mind. All the wounds you have to keep tetanus prophylaxis. So that is separate apart. But what is the most common one? Whether it is a staph, strep, or else you are thinking in terms of any other anaerobic organism. So when I will substitute an anaerobic organism is that there you said a dark necrotic patch. So when a dark necrotic patch is formation, then mostly we have to think whether an anaerobic infection already has set in or not. So your antibiotic selection should be depending upon the comorbidities of the patient, the risk factor. What we mean by risk factor? The trauma related risk factor. Maybe I am giving you a history that this is a fisherman. Is a fisherman.
Vibrio, but
you have to think about Vibrio vulnificus and also Mycobacterium also. Mycobacterium marinum. Mycobacterium marinum also you need to think of. So that are the differences. So you have to think risk factors. When we talk regarding risk factor, we generally think of diabetes, all those things. Risk factor of the professional risk factors, what is the type of injury that he has got, all those things. Animal bite, again, when you are animal bite, again chance of anaerobic infection, because a lot of anaerobes will be there in their oral cavity. So that can cause anaerobic infection. So what is the type of injury is very, very important in this. This is not true for this. Every cases what we are dealing as a cellulitis, we should know. So again, you said there is a thorn or something that you have to remove that foreign body. Without that removal of foreign body, there is no treatment in that. So that part you need to take in care. Now your antibiotic of choice. What antibiotic you want to start in the ED for this patient? For this patient, I am not saying for any deep palmar abscess. For this patient, what you wanted to start, and I want to know what rationally, what organisms you wanted to cover.
So gram positive, gram negative, anaerobic coverage, and also toxin coverage you have to.
I will put this way. I will put as gram positive, anaerobic, toxin gram negative. So that is the way, because my concern will be firstly gram positive, followed by an anaerobic, maybe toxin mediated also is there some amount, and finally a gram negative. So gram negative skin infections are not very common, but very rarely you need to consider that. So that is our priority. So your antibiotic selection should be justifying these things and what antibiotic he has received also already.
So he has initially received amoxicillin. So we have to give gram positive coverage and anaerobic coverage. So we can give a piptas. Piptas can cover the board, and clindamycin can be given for a toxin, antitoxin effect.
Also anaerobic.
And anaerobic coverage.
Piperacillin tazobactam will help you for your gram positive as well as for your gram negative, and for toxin mediated and for anaerobic clindamycin will help. So clindamycin has got two properties. So that is the reason why tetanus also we can give. It has got good anaerobic coverage. Below the diaphragm, any infection you wanted to treat, you think of metronidazole, but above the diaphragm, it is always clindamycin. And on skin infection, it is always better to go ahead with clindamycin. MRSA as such, I won't suspect him at this point of time, unless and until he has been inside an hospital for few days. He's coming from the community as such, I won't suspect an MRSA. But he's there for a long time in another hospital, 3-4 days, one IND has been done, but still the sepsis is not resolving, then you need to cover MRSA also. So our will be gram positive, anaerobic infection, then toxin coverage, then gram negative and MRSA. So he is not coming from another hospital, that's why I have removed the MRSA. So, and rarely, if it is not improving, what you need to think, melioidosis also. Not hand space infection, any other cellulitis or septic arthritis, non-resolving, diabetic, you have to consider melioidosis and tuberculosis as one of the cross differentiate. So that is how you need to start. So our rationale will be to start piperacillin tazobactam, gram positive as well as gram negative coverage, anti-pseudomonal penicillin, very good coverage will be there. And another important thing is that where you wanted that coverage to happen. Suppose you are treating for a brain infection, piperacillin won't cross the blood-brain barrier. But skin and bone jaws infection, it has got reasonable coverage. And again, the next option will be clindamycin, anaerobic with toxin mediated. So these are the two antibiotics that is required. Depending upon the type of injury, I will decide whether to give a tetanus vaccination or tetanus immunoglobulin. But it's almost 10 days now. So even if you want to give tetanus vaccine, it is not going to help much, but still you can give an immunoglobulin depending upon the exposure and what is his previous vaccination status. If he is completely vaccinated, he is fully vaccinated and it's not a tetanus prone wound, you need not do anything. But if he is not fully vaccinated and it's a tetanus prone wound, then definitely you need to give head with the tetanus vaccine followed by your tetanus immunoglobulin. That is the antibiotic per se. Then pain management, very important pain management. Definitely you need to give good analgesics, and maybe once you drain the abscess only, it will come down. So the risk factors also you need to think in your mind. Vibrio olnificus, piperacillin tazobactam will cover. Mycobacterium marinum, then you need to have, sometimes you need to change your anti-tuberculosis. So the culture of that tissue, that once you are draining and you are sending it for culture, is very important. Here he is not a fisherman, he is just a normal person who was just doing a household work and suddenly had, while removing the coconut husk, he has developed this. So that is the treatment. Suppose imagine this patient has come to you for the first time. So what antibiotic you wanted to start? Maybe just after a trivial trauma he had come to you.
So we can start with amoxicillin itself.
Amoxicillin. See, problem with amoxicillin is a very good antibiotic, I am not agreeing, but when you have a risk factor, you giving amoxicillin plain might not be beneficial. So you can go with amoxicillin with clavulanic acid. So that might be an option when he comes initially and he is not having any risk factor. Even flucloxacillin is a very good option. You can start off with a simple flucloxacillin. Even for septic arthritis, we can give flucloxacillin. There is no harm in giving flucloxacillin. 1 gram 6 hourly, you can start off. Palmar tenosynovitis. Palmar tenosynovitis, again, ultrasound is a very good tool, because tenosynovitis you will be able to differentiate, and what all you need to, again you can give augmented, that you can start 625 TID for 7 days, and mostly this is tenosynovitis, so you need to give some local applications also. So maybe some diclofenac gel for locally, and maybe some glycerin maxil dressing over that area will help to decrease the edema. So that patient that I was talking before responded very well for augmentin, and her pain, everything got significant reduction. So you have to think, we don't see anything redness or anything as such over the skin, but there will be some swelling, and only that lady had a significant pain while doing the finger movement, specifically the thumb. So that is a group of patient, and definitely a surgical drainage is required. So you should not delay the source control. You are giving antibiotics well and good, but you need to definitely give antibiotics, and drainage also needed to be done. So what has been done for this patient?
So we done with the incision and drainage, and further if debridement needed, debridement.
Okay, fine. Anything else that you want to add on?
Mostly the patient will have a superficial and deep space infection.
Okay.
Superficial infection usually skin and subcutaneous tissue. Most common causes will be, as discussed, animal bite, thorn bricks and all. Whereas in deep infection we'll have which will involve bone, the joints and tenosynovitis, synovial space. And we can divide synovial space infection then in the space of peyronie, then flexor tenosynovitis, thenar, hypothenar and mid-palmar infections. And mostly the differential diagnosis will be like gout, pseudo gout, and then calcific tendinitis, then pyoderma gangrenosum, foreign body retained foreign bodies. That's will.
Okay, fine. Thank you.